Hello, I'm Dr. William Mills, and I'm here to present a paper entitled Days Spent at Home as an Outcome Measure for People with Intellectual and Developmental Disability. This paper was accepted for presentation at the American Association on Intellectual and Developmental Disabilities 2020 National Meeting. First is background. There has been increased usage of value-based outcome measures in many population health initiatives in the United States. However, there is little research about which value-based measures may most specifically apply to the field of IDD. Hospitalization rate is an outcome measure that is being used as a reportable measure at a number of current and emerging population health initiatives. Days spent at home as a newer measure is person-centered in that it can measure the time that an individual spends at home and in the community outside of hospitals and nursing homes. We sought to build an algorithm to determine the annual hospitalization rate as well as the mean days spent at home in our cohort of individuals with IDD during a one-year study period who were enrolled in residential waiver programs in 12 states. Our methods were as follows. Between October 2018 and September 2019, the population of IDD residential waiver clients were provided continuous person-centered support and care and medically necessary services. Each individual's whereabouts was entered into a database called Interactants each day, letting us track whether that individual was at home in the community or in a hospital, nursing home, or on leave. We then performed a retrospective review of the database to track length of stay and the days spent at home during the year. Total managed days was calculated as the days an individual that we were providing service for was utilizing our services minus the days that individual was on therapeutic leave or incarcerated. Hospitalization rate was calculated using standard measures, as was inpatient days per 1,000, and days spent at home was very simply calculated as the total number of days in the year that an individual was within our support and care minus the days that individual spent in hospitals or nursing homes. Our results. During the one-year study period, we provided service for just under 2,400 individuals in residential community living programs for a total of about 750,000 managed days. The population's average age was 46, and most had concomitant IDD, medical, and behavioral diagnoses. During the year, 20% of individuals with IDD were hospitalized, and the length of stay varied widely between 1 and 229 days of inpatient length of stay. Hospitalization rate was calculated as 240 per 1,000 managed person years. Inpatient days was 5,243 over 1,000 people that were cared for during that year study period. And the cohort spent an average of 360 days per home during the year, or 98.5% was spent outside of hospitals and nursing homes. We then sought to assess whether there was significant geographic variation in the days spent at home in the population with IDD, and we found that the average days spent at home ranged between 354 and 365 days in the 12 states shaded in varying colors of blue. In conclusion, hospitalization rate and days spent at home may be emerging value-based outcome measures in IDD. Individuals in the waiver programs that we followed for a one-year study period had a hospitalization rate of 240 admits per 1,000 per year. And that same population resided in home-based settings outside of inpatient settings 360 days per year on average. While most individuals were not hospitalized during the year, a small subset had a very long length of stay that was more than likely, in most cases, related to behavioral diagnoses that were refractory to routine outpatient treatment. We took the liberty to put together a roadmap that leaders in IED may choose to utilize in further developing value-based outcome measures. First, developing value-based outcome measures and testing them is important. Second, using health information exchanges along with other data sources to facilitate data collection and reporting. 3, to increase value-based outcome presentations and publications by both academia and industry. 4, to develop and refine risk stratification models as well as benchmarking of the newly identified value-based measures. And 5, finally, to have hopeful wide-scale adoption of pay-for-value payment models in the field of IDD. In the future, studies of new models of support and care for people with IDD in which augmented outpatient behavioral health supports are available are needed. Such studies should also evaluate whether more intensive outpatient behavioral supports integrated with IDD and medical management may help to drive hospitalization rates and inpatient days per 1,000 lower. Studies of enablers optimizing hospitalization rate and days spent at home will be very important. Looking at various factors such as access to care, care management approaches, focusing on medication management, and care coordination between the various providers of both support and care. Hospitalization rate and days spent at home are very simple metrics that may promote provisioning of even more appropriate resources for individuals with IED within waiver programs and also into managed care and new emerging payment programs. In conclusion, I want to extend a heartfelt thanks from both my co-authors and myself to all the direct support personnel, caregivers, and nurses for what you do every day for people with IED throughout the country, especially during this challenging time. Thank you very much.